Now see this question. All of the following are true about Arnold-Chiari malformation except. Arnold-Chiari malformation is very important. It is asked in both surgery as well as pediatrics. So before discussing this question, we are going to discuss Arnold-Chiari malformation. So this Arnold-Chiari malformation, it is of two types, type 1 and type 2. Now see what is type 1. In type 1, there is displacement of cerebellar tonsil into cervical canal, and generally it is associated with syringomyelia of cervical canal. But be careful, type 1 Chiari malformation is not associated with hydrocephalus. It is associated with syringomyelia. This is frequently asked question. It is associated with syringomyelia, but it is not associated with hydrocephalus. Now, the presentation of this condition, generally patients develop symptom during adolescence or adult life. So question, what are the symptoms? These patients are having recurrent headache, sometimes neck pain, there is increased urinary frequency, and there is progressive lower extremity spasticity. Now see what is type 2 Chiari malformation. This is going to represent the anomaly of hind brain. Now in this case, what's the problem? There is elongation of fourth ventricle and kinking of brainstem. There is displacement of inferior vermis, pons and medulla into cervical canal. I told you type 1 is not associated with hydrocephalus, and can you see type 2 is associated with progressive hydrocephalus with meningomyelocele. Now in this case, actually there is small posterior fossa and there is widened cervical canal. How we have to treat this? This anomaly is treated by surgical decompression. Now see the question. So all of the following are true about Arnold-Chiari malformation except. First, type 1 is displacement of cerebellar tonsil into cervical canal. This is correct. Type 2 Chiari malformation is associated with syringomyelia of cervical canal. Be careful, it's not the type 2 actually it's the type 1 which is associated with syringomyelia of cervical canal. Now see, type 2 Chiari malformation is characterized by elongation of fourth ventricle, kinking of brainstem and displacement of inferior vermis, pons and medulla into cervical canal. This is also correct. And type 1 Chiari malformation is not associated with hydrocephalus. This is also correct. So correct answer for this question is B. Before discussing this question, you should understand that what is meningocele and what is meningomyelocele. Now see the word meningocele, and there is meningomyelocele. So what is the problem? In meningocele, there is defect in posterior vertebral arches and there is herniation of only meninges. And in meningomyelocele, there is herniation of both meninges plus spinal cord. Now second, out of meningocele and meningomyelocele, which one is severe dysraphism? Actually, it's the meningomyelocele, and see, it's the most severe type of dysraphism. Question is asked, what's the most common site of meningomyelocele? It's the lumbosacral region. If you have seen the patient in emergency or in the labor room or in pediatrics or in neurosurgery department. In meningocele, since there is only herniation of meninges, the content is clear, that is CSF, and these meninges are covered with skin. So this is a brilliantly transilluminant swelling. Have a look how it looks like. So here you can easily make out that it's A, which is meningocele, which is a brilliantly transilluminant swelling, and here the content is spinal cord also. So this is meningomyelocele. The good thing about meningocele that in majority of cases it is covered with skin. That's why we can go for delayed treatment also. But the problem, if skin is broken, Because of broken skin, there is increased risk of infection, especially meningitis. So if skin is broken, in that particular case, we have to perform immediate surgical intervention. Now see the question. All of the following are true about meningocele except spinal cord is usually normal. So spinal cord is usually normal in meningocele, assumes a normal position in spinal canal, correct? Most meningoceles are well covered with skin and pose no threat to the patient. Also correct. Brilliantly transilluminant, correct. Immediate surgical treatment is required to prevent meningitis in all the patients, not in all patients, in certain patients where skin is broken. So correct answer for this question is D. Now see this question. All of the following are true about myelomeningocele except. What is the most common site? Most common site is lumbosacral region. This is correct. There are certain drugs which increases the risk of myelomeningocele or neural tube defects. Question: what are those drugs which increase the risk of neural tube defects? So see the list of drugs. It is trimethoprim, carbamazepine, phenytoin, phenobarbital, primidone and valproate. So basically these are anticonvulsants. These drugs and trimethoprim, that is antibiotic, these drugs increases the risk of neural tube defects, especially the meningomyelocele. That's why in all the females of childbearing age and who are capable of becoming pregnant, we have to give 0.4 mg of folic acid daily. So now see the second option, carbamazepine increases the risk, correct. Maternal periconceptional use of folic acid supplementation reduces the risk, correct. All women of childbearing age and who are capable of becoming pregnant take 0.4 mg, be careful, 0.4 mg of folic acid daily. So correct answer for this question is D. This question is based on the latest AIIMS pattern exam. See the question. Which of the following statement about Dandy-Walker syndrome are true and which are false? This topic is very important, Dandy-Walker syndrome. So before discussing the question, let us first discuss what's Dandy-Walker syndrome. So have a look of Dandy-Walker malformation. It's the most common posterior fossa malformation. It's rare. Generally the prevalence is 1 in 30,000 live births. So it's rare. What is the problem in this case? There is cystic expansion of fourth ventricle and there is midline cerebellar hypoplasia. Midline cerebellar hypoplasia. What is the problem? It is actually a developmental failure where in the roof of fourth ventricle during embryogenesis. The question which is frequently asked is that what's the triad of Dandy-Walker malformation? And the triad is hypoplasia of vermis, cephalad rotation of Vermean remnant and cystic dilatation of fourth ventricle, and there is enlarged posterior fossa. Enlarged posterior fossa. Clinical features. The most common manifestation is that patient is having macrocephaly and there is associated hydrocephalus also. You can see macrocephaly is seen in 80% cases, hydrocephalus in 90% cases. Now what is the problem? These children or these infants present with rapid increase in head size and prominent occiput. Question why? Because there is hydrocephalus. So there is rapid increase in head size and prominent occiput. Most of these children have evidence of long tract sign, ataxia, delayed motor and cognitive milestones. Why? Because of these structural abnormalities. Now, in more than 70% cases, there are associations like agenesis of posterior cerebellar vermis, corpus callosum, and generally how we are going to make the diagnosis of this condition? MRI. Now, see the question. So, first option, it's the most common posterior fossa malformation. This is true. It consists of cystic expansion of fourth ventricle in posterior fossa, and midline cerebellar hypoplasia. This is also true. It's triad of hypoplasia of vermis, cephalad rotation of vermian remnant, and cystic dilatation of fourth ventricle extending posteriorly, and enlarged, be careful, and enlarged posterior fossa. So this is false. Most common manifestation is macrocephaly. It's true. Managed by shunting the cavity. This condition is managed by shunting. Why? Because in 90% cases there is hydrocephalus. So this is also true. So only third is false, rest all are true. So only third is false, rest all are true. So correct answer for this question is B. CVA, cerebrovascular accidents, are asked both in medicine as well as in surgery. And these are frequently asked one-liner questions. So have a look of all those one-liner questions which are frequently asked about this cerebrovascular accidents. First question is about causes of CVA. So there are two causes. One is ischemic and second is hemorrhagic. Which one is most common? 85% is ischemic and 15% is hemorrhagic. Now in ischemic, most common is what? Embolic occlusion, responsible for 75% cases. Second is thrombotic. In hemorrhagic cerebrovascular accident, there is parenchymal hemorrhage, which is most commonly responsible. After that, subarachnoid hemorrhage, and then epidural, and then subdural hematoma or hemorrhage. Now see two important questions related to hemorrhagic cerebrovascular accident. First, intracerebral, which is also known as parenchymal hemorrhage. So this is the most common type of intracranial hemorrhage. And what is the most common cause? Hypertension. So people or patients who have uncontrolled hypertension, this is one of the emergency presentation. What is the cause? Because of rupture of small perforating arteries or arterioles. What is the most common site? It's the basal ganglia. And in the basal ganglia, what is the most common site? Putamen. Now see the subarachnoid hemorrhage. It's the second most common cause of intracranial hemorrhage. What is the most common cause of subarachnoid hemorrhage? It's the trauma. Trauma followed by spontaneous rupture of Berry aneurysm. And generally you must be knowing what's the most common site of Berry aneurysm. It's in anterior circulation of circle of Willis. So now see the question. All of the following are true about cerebrovascular accidents except most common cause is embolic occlusion. Correct? Most common cause of intracerebral hemorrhage is hypertension. Correct? Most common cause of subarachnoid hemorrhage is actually trauma. It's trauma followed by rupture of Berry aneurysm. So this is incorrect. Most common site of intracerebral hemorrhage is putamen. This is also correct. So correct answer for this question is C. Berry aneurysm is very important. Very important. Now see, all of the following are true about Berry aneurysm. You know that Berry aneurysm is most common type of intracranial aneurysm, and the location is in the anterior circulation of circle of Willis. In that, what is the most common site? It's the anterior communicating artery and anterior cerebral artery junction. So this is anterior circulation. Generally in Berry aneurysm, what is the most common site of rupture? It's the dome or apex. And how we manage the patients of Berry aneurysm? Be careful, nowadays most of the patients are managed by endovascular coil occlusion, and endovascular coil occlusion is preferred over surgical clipping. So see the question. All of the following are true about Berry aneurysm except most common type of intracranial aneurysm. Correct? Most common site is anterior communicating artery, anterior cerebral junction. Correct? Rupture of aneurysm usually occurs at apex or dome. Correct? surgical clipping is preferred over endovascular coil occlusion. It's the vice versa actually. Endovascular coil occlusion is preferred over surgical clipping. So this is preferred. So correct answer for this question is D. Now see this question. A 30 years old patient of head injury was brought to the emergency. NCCT was performed. Findings are given below. All of the following are true about this condition except. First question. What is this condition? So you can see here, this is the biconvex hematoma. So it's lenticular shape or biconvex. So classically it is what? EDH, extradural hematoma. Now just have a look of this diagram. Suppose this is skull and this is brain. In between skull and brain there is a pad. Pad means outermost dura, then arachnoid and then pia. If the blood is collected between skull and dura, this is known as extradural. And if the blood is collected between dura and arachnoid, this is known as subdural. Now see the shape. The shape of extradural is biconvex, but subdural is concavo-convex. Second, you can see the picture. The EDH is red colored. I made it red colored, and SDH is made blue colored. Why? Because the bleeding is arterial in EDH and venous in SDH. Why? Have a look. There is a weakest point in temporal bone that is known as pterion. Beneath pterion there is middle meningeal artery. So even trivial trauma to this region can lead to injury of middle meningeal artery, and that leads to EDH, extradural hematoma. What's the cause of subdural hematoma? Significant trauma. Acceleration or deceleration leads to injury of cortical veins or bridging veins, and that leads to subdural hematoma. It means bleeding is venous in SDH. But be careful, significant trauma is required in SDH. Both of these are diagnosed by NCCT, non-contrast CT, and in both drainage should be done. Generally, EDH is drained by burr hole. SDH is usually drained by craniotomy. But what's the good thing about SDH? That if small hematoma is there, that can be observed if the patient's clinical condition is stable. But what is the bad thing about SDH? It is having poor prognosis as compared to EDH. In EDH, there is lucid interval which is positive. Lucid interval means patient becomes unconscious because of head injury, and then become conscious and then again unconscious. So there should be one episode of consciousness after unconsciousness. That is lucid interval. So now see the question. All of the following are true about this condition, that is EDH, except it's arterial bleeding. Correct. Lucid interval is positive. Correct. Full recovery is rare even after treatment. Actually, full recovery is seen in majority of patients after the treatment. So this is incorrect. Immediate surgical evacuation should be done. Generally, we have to go for immediate surgical evacuation. So correct answer for this question is C. Okay, now see this question. A 60 years old patient was brought to the emergency after road traffic accident. NCCT head was performed and the findings are given below. All of the following are true about this condition except. Now can you see what kind of collection is here? You can see the shape is concavo-convex, and if you can make out, this is the midline. So you can see here that there is midline shift also. Can you see the age of patient? 60. Road traffic accident means significant trauma. So this condition is what? Subdural hematoma. And in subdural hematoma, blood collects between dura and arachnoid. Now see, blood collects between dura and arachnoid, correct? Caused by disruption of cortical veins or bridging veins, correct? Evacuation should be done in all the cases. Not all the cases. I told you small SDH can be managed conservatively. So this is incorrect. associated with significant primary brain injury. Yes, it's correct. Why? Because it is associated with significant trauma. So, correct answer for this question is C. Now, see this question. An adult hypertensive male presented with sudden onset severe headache and vomiting. On examination, there is marked neck rigidity and no neurological deficit was found. The symptoms are most likely due to. Now, see, meningitis is ruled out. Why? Because there is no evidence of infection, there is no evidence of fever. Ischemic stroke is ruled out. Why? Because there is no neurological deficit. Intracranial parenchymal hemorrhage is also ruled out. There is no neurological deficit. Now see, what is this subarachnoid hemorrhage? I told you the most common cause is trauma followed by rupture of Berry aneurysm. In this case, what happens? There is transient loss of consciousness, but there is excruciating severe headache. This is very important symptom. Excruciating severe headache. Sometimes patients are going to tell that it was the worst headache of my life. But what is the good thing? That in this case there is no neurological deficit. So correct answer for this question is D, that is subarachnoid hemorrhage. Diffuse axonal injuries are very important. So before discussing this question, let's first discuss the diffuse axonal injuries. So in this diffuse axonal injuries, the term is self-explanatory. What is the problem? Diffusely, there is injury of axons. It means there is widespread axonal damage, means white matter damage in both of the hemisphere. Now, what kind of injury is going to cause this diffuse axonal injuries? Generally, it's the acceleration or deceleration or angular strain. So, what will happen generally? There is presence of shearing force because of acceleration, deceleration or angular strain. There is shearing force on the axons and that leads to diffuse axonal injuries. What's the most common location? It's the lobar white matter at the junction of gray and white matter, followed by corpus callosum, followed by brainstem. Now, what is the problem? In this case, there is both hemorrhagic as well as non-hemorrhagic white matter tears in both cerebral hemisphere. Now see the presentation. These patients at the time of presentation usually have the state of coma. So there is concussion to coma. Now what is the problem? In most of these patients there is loss of consciousness and they go into vegetative state or in the coma. Diffuse axonal injury is the most common cause of post-traumatic vegetative state. Now see, in certain patients, intracranial tension is increased. It might be normal also. What's the problem? Generally, in head injury patients, we perform NCCT, that is investigation of choice. But diffuse axonal injuries are not diagnosed on NCCT. So for this particular condition, investigation of choice is what? MRI. So here, the investigation of choice is MRI, and I told you most of the patients are in vegetative state or in the state of coma, and that's why here the prognosis is very poor prognosis. Now see the question. All of the following are true about diffuse axonal injuries except injuries to axons by shearing force, correct? Most common location is lobar white matter at junction of gray and white matter, correct? Associated with raised ICT in all the cases, not all the cases, in certain cases. MRI is investigation of choice. So correct answer for this question is C. Before discussing this question, have a look of important points related to brain tumors. Now see, what is the most common primary brain tumor? Initially it was astrocytoma, but now it's meningioma. So most common primary brain tumor is meningioma, responsible for 35% cases, followed by glial tumors, which are responsible for 30% cases of primary brain tumor. Second question, overall most common brain tumor is metastasis. That's also known as secondaries. Third question, what's the most common malignant brain tumor of children or childhood? So, most common malignant brain tumor of childhood as well as most radiosensitive brain tumor is medulloblastoma. Then question is asked related to calcifications associated with brain tumor. So it's the craniopharyngioma, followed by oligodendroglioma, followed by meningioma. Mnemonic is CALM. Most of craniopharyngiomas are associated with calcification, followed by 90% of oligodendroglioma are associated with calcification, and followed by meningioma. Approximately 20 to 25% patients of meningioma are having calcification, are associated with calcification. So these are one liner questions related to brain tumors. Most brain tumor occur sporadically. So what are the risk factors for brain tumor? There are two established risk factors. One is radiation exposure and the second is genetic abnormalities. Lots of questions are asked related to genetic abnormalities associated with brain tumor, and the mnemonic is RL not in MTVGT. R means retinoblastoma, L means Lee-Fraumeni syndrome, N means neurofibromatosis 1, neurofibromatosis 2, M means MEN1, be careful, MEN1, Turcot syndrome, VHL syndrome, Gorlin syndrome, and tuberous sclerosis. So the mnemonic is RL not in MTVGT. After that, what are the clinical manifestations and how we are going to manage the brain tumors? Generally, in brain tumors, there are three cardinal symptoms. First, seizure. Second, raised intracranial tension. And third is focal neurological deficit. Because of this raised intracranial tension, what's the problem? This patient is having headache. And this headache is worse in morning and straining. And generally, this headache is associated with nausea and vomiting. Second, there is brain tumor. The size of tumor will increase over a period of time, and that's why what will happen? The focal neurological deficit is also progressive. Second, the deficit depends on the location. So, depending upon the location of tumor, there will be characteristic focal neurological deficit. Sometimes patients are having pituitary adenoma, and if it's a functional adenoma, these patients will be having endocrine abnormalities. How we make the diagnosis of brain tumors? Generally, investigation of choice for diagnosis is MRI. There are certain basic treatment protocols which should be followed during management of brain tumors. So see the important points related to management or treatment of brain tumors. Now, in brain tumors, we give steroids or dexamethasone. What is the use? It is going to decrease the peritumoral edema. Second, anti-epileptics should be given for the tumors which are close to sensory motor strip. So, for tumors close to sensory motor strip, we have to give anti-epileptics. Mannitol by osmotherapy is going to decrease the intracranial tension. So, it is administered before dural opening and operative resection. What is the primary goal of surgery? Surgery, the primary goal is histologic diagnosis. So you have to confirm that what kind of tumor is there. And second, reduction of mass effect. But be careful, whenever we are reducing the mass effect by excision of tumor, yes, we have to preserve the neurological function. There are situations where without there are situations where if we are going for tumor resection, we are going to compromise certain neurological function. In those cases, we remove the maximum amount of tumor and we leave some amount of tumor inside. Means the margin is still positive, tumor is still left, and in post-operative period, that tumor remnant is taken care of by radiotherapy. So that's why if there is positive margin or tumor is infiltrating the surrounding brain, we have to go for radiotherapy. Then craniospinal irradiation. This craniospinal irradiation is specially used for tumors which are having CSF spread. What are the tumors commonly associated with CSF spread? That is medulloblastoma and ependymoma. So in these tumors, we have to give what? Craniospinal irradiation. These are the basic important points related to brain tumor. Now have a look of the question. Mark the true and false statement about brain tumors. Most common primary brain tumor is, be careful, it is meningioma. It's meningioma. So this is false. Radiation exposure and genetic abnormalities are the risk factor. This is true. MEN2, it's not 2, it's MEN1. MEN2 and NF1 increases the risk. It's false because it's the MEN1 and neurofibromatosis 1 and 2 both are going to increase the risk of brain tumor. Three cardinal symptoms are seizures, raised intracranial tension, focal neurological deficit. This is also true. Dexamethasone reduces peritumoral edema. True. Primary goals of surgery includes histological diagnosis and reduction of mass effect. True. Anti-epileptics for tumors close to sensory motor strip. True. Craniospinal irradiation for tumors associated with CSF spread. True. So only 1 is false and 3 is false. So 1 is false, 3 is false, rest all are true. So correct answer for this question is C. Before discussing this question, see what is stereotactic radiosurgery. So what is stereotactic radiosurgery? Have a look. So just break the word. It's radiosurgery. Actually speaking, it's not the surgery. It's a type of radiation therapy. So it's a type of non-surgical radiation therapy. In these cases, in stereotactic radiosurgery, we are going to treat the functional abnormalities and small tumors of brain. Now what happens here? The precisely targeted concentrated dose of radiation is delivered to a defined volume of brain. So in a defined volume of brain, what happens? Concentrated dose of precisely targeted radiation is given. So it is used to treat small brain tumors and functional abnormalities of brain. Second, if stereotactic surgery is used to treat body tumors, it is known as stereotactic body radiotherapy, in short known as SBRT. So whenever stereotactic radiosurgery is used to treat body tumors, it's known as stereotactic body radiotherapy. Now see what are the uses of this SRS, stereotactic radiosurgery. So these are the common 4 uses. First, brain tumors. What kind of brain tumors? Both benign, malignant, primary, metastatic, single, multiple. Second, benign lesions of cranial nerve. Third, AV malformation. And fourth, trigeminal neuralgia. Now how to remember? Mnemonic is BAT. Brain tumor, benign lesions of cranial nerve, arteriovenous malformation, and T means trigeminal neuralgia. So stereotactic radiosurgery is used in which of the following condition? Metastatic brain tumors, correct. AV malformations, correct. Trigeminal neuralgia, correct. So correct answer for this question is D. Now see, all of the following are true about brain metastasis. Brain metastasis is very important, and you know that most common brain tumor is brain metastasis. What is the most common primary for brain metastasis? The most common primary is carcinoma lung, followed by carcinoma breast. Carcinoma lung followed by carcinoma breast. We can manage brain metastasis by both surgery as well as radiotherapy. By both surgery as well as radiotherapy. Which type of radiotherapy is given? It's the WBRT, whole brain radiotherapy. Question is asked, what's the most common site of brain metastasis? Generally, it's the frontal lobe. It's the frontal lobe. And in brain, where exactly the tumor is located? It's located at the junction of gray matter and white matter. Generally, chemotherapy is not helpful in brain metastasis, but exceptions are there. If the metastasis is because of small cell carcinoma lung, if it's because of small cell carcinoma lung, or it's because of seminoma. The brain metastasis because of these two tumors, in that case, what we give chemotherapy. Now see the question. All of the following are true about brain metastasis except frontal lobe is most common site, correct? Lesions are located at gray matter and white matter junction, correct? Most common primary site is actually carcinoma lung, followed by CA breast. It's the carcinoma lung followed by CA breast. So this is incorrect. Chemotherapy can be used in brain metastasis due to small cell lung cancer and seminoma. This is also correct. So correct answer for this question is C. Now see this question. This question is about astrocytoma and types of astrocytoma. So before discussing this question, let us discuss in detail the astrocytoma. So astrocytoma, it means the tumor arises from astrocytes. Astrocytoma. Second, generally in children it is infratentorial and in adults it is supratentorial. Infratentorial means in children most common site is cerebellum and in adults it is supratentorial. It means most common site in adults is cerebral cortex. Third, in children most common type is pilocytic astrocytoma. Pilocytic. And in adults most common type is glioblastoma multiforme. So now see the characteristic features of various types of astrocytoma. There is a WHO classification for astrocytoma which is frequently asked. Now see, there are 4 types of astrocytoma. First is grade 1, second grade 2, grade 3, grade 4. Grade 1 is known as pilocytic astrocytoma, and this pilocytic astrocytoma is the most common astrocytoma in children. What is the good thing of this pilocytic astrocytoma? That only surgical resection is sufficient. Why only surgical resection is sufficient? Because this tumor is not going to encroach the surrounding brain. So there is no encroachment of surrounding brain, and that's why here only surgery is sufficient. Otherwise, in grade 2, grade 3, grade 4, what we have to give? Surgery plus radiotherapy, surgery plus radiotherapy, surgery plus radiotherapy. Why? Because in all these 3, there is encroachment of surrounding brain. Second, pilocytic astrocytoma. Here, there is discrete contrast enhancing cystic lesion with mural nodule. So generally it's a cystic lesion and there is a mural nodule. Out of these 4, this pilocytic astrocytoma is having best prognosis and this glioblastoma multiforme, this is having worst prognosis. Now see grade 2. Grade 2 is also known as low grade astrocytoma. It is generally seen in children and young adults. Presentation is seizures. In this case also, since there is encroachment, surgery plus radiotherapy is used. Now see anaplastic or grade 3. There is irregular enhancement on MRI. The treatment is cytoreductive surgery plus EBRT, means surgery plus radiotherapy. The most important is glioblastoma multiforme. Now see, the most important is this glioblastoma multiforme. Now see, in pathology questions are asked that there is endothelial proliferation or necrosis, and that makes these tumors grade 4. It is also known as butterfly tumor. Can you see why? It's also known as this butterfly tumor. Why? Because this tumor crosses midline. And if you see in this tumor, can you see that there is central necrosis with ring-like enhancement? So there is central necrosis with ring-like enhancement. Generally, it is seen in older patients age more than 50 years. This question was asked once in JIPMER, that central necrosis with ring-like enhancement is seen in which brain tumor? It's the glioblastoma multiforme. Treatment is surgery plus radiotherapy. Now, the survival is very low. Why? Because it is advanced malignancy. So, to improve the survival, generally one drug is helpful, and that drug is what? Temozolomide. So temozolomide, specially, what's the role of temozolomide in the management of newly diagnosed and recurrent glioblastoma multiforme? What are the two other agents which are used? It's the carmustine and cisplatin. So this is the glioblastoma multiforme, one of the most important brain tumor which is frequently asked in exam. Now let's discuss the question. Now see, astrocytoma. Astrocytoma is mostly supratentorial in adults and infratentorial in children. So H, 1H, pilocytic astrocytoma is most common astrocytoma in children. So 2 is E, low grade astrocytoma is type 2, occur in young adults and most patient present with seizures. That is A. Anaplastic. Anaplastic, the treatment is cytoreductive surgery followed by EBRT. So that is B. And you know, same treatment is also done in glioblastoma multiforme. So for 5 also it is B. Now see, endothelial proliferation or necrosis on histology. It is seen in glioblastoma multiforme. Butterfly tumor, glioblastoma multiforme. Temozolomide, glioblastoma multiforme. And radiation therapy and chemotherapy has no role. Radiation therapy and chemotherapy has no role. In which one? Pilocytic astrocytoma. Clear? Because it is not going to infiltrate the surrounding brain. So this is the combination 1H, 2EG, 3A, B, 4B, 5BCDF. So the best combination is here, this C. So correct answer for this question is C. Now let's discuss the question directly. First, oligodendroglioma. So what is the characteristic feature of oligodendroglioma? It is characterized by fried egg cytoplasm, chicken wire vasculature and microscopic calcification. So 1 is C. After that, most common site is frontal lobe of oligodendroglioma. So it's G. And in oligodendroglioma also what we use? Temozolomide, H. Now see ependymoma. Ependymoma is the most common histological type of ependymoma in adults. It's myxopapillary. It's the myxopapillary. And I told you that in ependymoma what kind of spread is going to occur? CSF spread. So here A and F. After that, meningioma. Meningioma mostly occur along the superior sagittal sinus. So it's mostly occur along superior sagittal sinus. It arises from meningomesothelial cells of arachnoid. So here for 3 it's D. And medulloblastoma is the most common malignant brain tumor of childhood. So it's B. After that, it's most radiosensitive brain tumor, E. And you know that CSF spread is also seen. So this is the combination. First CGH, second ANF, third D, fourth BEF. So correct answer for this question is D. Now before discussing this question, let us first discuss what is hemangioblastoma. Hemangioblastoma is very important, frequently asked in both pathology as well as in surgery. Sometimes it is also asked in radiology. It is the most common primary intraaxial tumor in the adult posterior fossa. Generally, exclusively it is occurring in which part of brain? Cerebellum. So exclusively it's occurring in the posterior fossa. What is the problem? Here is the tumor. The tumor is the cystic. The tumor is cystic and there is a mural nodule in the wall. So there is a mural nodule in the wall. It can occur sporadically. This question is asked. 20% are associated with what? VHL syndrome. And what are the associations in VHL syndrome? Hemangioblastoma, retinal angioma, RCC, pheochromocytoma, renal and pancreatic cyst. Another important question which is asked that these hemangioblastomas are going to produce erythropoietin, and because of production of erythropoietin, what happens? There is polycythemia. The good thing is that these hemangioblastomas are benign. These are benign tumor. Now see the question. All of the following are true about hemangioblastoma except it's the most common primary intraaxial tumor in adult posterior fossa, correct? It's solid or cystic with mural nodule, correct? Polycythemia is due to increased erythropoietin production, correct? It's a benign condition. So correct answer for this question is D. It's not premalignant, it's a benign condition. We discussed medulloblastoma. I told you it's most common malignant brain tumor in children and it's most radiosensitive. It's most radiosensitive brain tumor. It's more common in children. And what is the most common site? It's the cerebellum. In cerebellum, generally in children, the most common site in cerebellum is what? This vermis. And in adults, the most common site is lateral cerebellar hemisphere. Now see, it's the most radiosensitive tumor, but be careful. Despite of being most radiosensitive brain tumor, the treatment of choice is what? Surgical resection. Second important point, there is CSF spread in the tumor, and since there is CSF spread, we have to go for what? Craniospinal irradiation. In certain patients, we give chemotherapy, and generally what are the agents? We give carmustine and vincristine. Carmustine and vincristine. In which cases we give carmustine and vincristine if there is recurrence or the age of child is less than 3 years to avoid radiotherapy. So see certain important points related to management of medulloblastoma. So first important point, despite of extreme radiosensitivity, it should be surgically excised. After surgical excision, we give radiotherapy and chemotherapy, and I told you we give carmustine plus vincristine for recurrences in poor risk patients and children less than 3 years to avoid radiation therapy. Now see the question. All of the following are true about medulloblastoma except occur predominantly in children, correct? Most common site is vermis, correct? In adults, it's lateral cerebellar hemisphere. Carmustine and vincristine are used for recurrences, correct? Children less than 3 years to avoid radiation therapy, correct? Radiotherapy is the main treatment modality, be careful. Despite of being very radiosensitive, what main treatment is surgical resection. So correct answer for this question is D. Now have a look of this question. All of the following are true about this brain tumor. Now tell me what's the name of this brain tumor. This is meningioma. How you can identify? Because it is arising from dura, and which tail is there? You can see that there is dural tail. It's the most common intracranial extraaxial dural based neoplasm. And generally, depending upon the location, see characteristic symptoms. What? This patient is having spasticity or lower limb weakness. There is sensory deficit and sphincter function of bladder. We told you in the beginning, or we discussed in the beginning, that calcification is seen in 20 to 25% cases. And there is one question. For meningioma, we follow this Simpson grading system. Simpson grading system. There is one very important question which is asked in radiology. What? The question is about various radiological signs. So have a look of various radiological signs in meningioma. All meningioma enhance intensely following contrast administration. There is abnormal vascular markings, enlarged foramen spinosum. There is dural tail. This is frequently asked. I told you calcification is seen in 20 to 25% cases, and this feature sunray spicules or bony hyperostosis. bony hyperostosis, also known as blistering, is seen. What is this blistering, bony hyperostosis or sun ray spicules? It is just like these kind of spicules from the skull. And why it is seen? Because of invasion of bone. And because of invasion of bone, what happens? There is localized bony hyperostosis or mixed osteoblastic and osteolytic response. So because of this, suppose this is skull, because of this mixed osteoblastic and osteolytic response, these kind of protrusion is there. These looks like spicules, sun ray spicules, and this bone expansion with pneumatization is called blistering. In this tumor, there is increased intracranial tension. So on radiology also you will find signs of increased intracranial tension. Now see the question. All of the following are true about this tumor, that is meningioma, except it's the most common intracranial, extraaxial, dural based neoplasm, correct? Associated with spasticity and lower limb weakness, sensory deficit and sphincter dysfunction of bladder, correct? Calcification is seen in, be careful, 20 to 25% cases, and Simpson grading system is used for meningioma resection. This is correct. So correct answer for this question is C. Lots of questions are asked about suprasellar masses. Suprasellar masses. So see first question. What's the most common suprasellar mass in children? That is craniopharyngioma. And what is the most common suprasellar mass in adults? That is pituitary adenoma. First question. So most common suprasellar mass in children, craniopharyngioma. Most common suprasellar mass in adults, pituitary adenoma. Now see, this pituitary adenoma can be functional or it can be non-functional. If it is functional, obviously patient will be having endocrine abnormalities. So question is asked, what's the most common cause of hyperpituitarism? It's a functional tumor in the pituitary. And what's the most common functional pituitary adenoma? And that is prolactinoma. That's prolactinoma. Now, for the treatment of prolactinoma, what we can use? We can use dopamine agonist. And what's that dopamine agonist is used? That is bromocriptine. So we can use bromocriptine. Bromocriptine can be used for other pituitary adenomas also which are functional, but what? It's not that helpful. Now see the second pituitary adenoma, that is growth hormone secreting pituitary adenoma. And if there is secretion of growth hormone, there is a better agent than bromocriptine. And what's that? That's octreotide. So octreotide is going to decrease the level of growth hormone in growth hormone secreting pituitary adenoma. Suppose we have to perform the surgery in pituitary adenoma. Which approach is preferred? It's the sublabial or intranasal transsphenoidal approach for resection of pituitary adenoma. So see certain important points related to treatment of pituitary adenoma. I told you we use bromocriptine, that is dopamine agonist. It can shrink prolactinoma in how many cases? 75% cases. With macroadenoma within 6 to 8 weeks. But what is the problem? It can work for growth hormone secreting tumors, but shrinkage is less than 20% only. And that's why it's the octreotide which can reduce the growth hormone levels in 71% patients, and significant tumor volume is reduced. Tumor volume is reduced significantly. So you have to remember that if the patient is having prolactinoma, generally we are using which agent? It's the bromocriptine. And if it's growth hormone secreting adenoma, generally octreotide is preferred. Now surgical approach is the sublabial or intranasal transsphenoidal approach. Question is asked, in which cases we have to go for surgery as an initial treatment? Now see, if patient is having growth hormone secreting tumor, primary Cushing disease, any adenoma which can cause acute visual deterioration because it is going to compress the optic chiasma, or there is non-prolactin secreting macroadenoma and the symptoms are because of mass effect. So these are indications of surgery where surgery is used as an initial treatment option. Now see the question. All of the following statements are correct about supraciliar masses except most common supraciliar mass in children, craniopharyngioma, correct? Most common cause of hyperpituitarism, pituitary adenoma, correct? Dopamine agonist is preferred over octreotide in the treatment of growth hormone secreting pituitary tumor. This is incorrect. What we prefer? We prefer octreotide, not the bromocriptine. Sublabial or intranasal transsphenoidal approach is used for pituitary adenoma, correct? So, correct answer for this question is C. Now see this question. All of the following are true about primary CNS lymphoma. Now, due to rising incidence of transplantation worldwide, there is increased incidence of patients who are immunocompromised, either because of receiving immunosuppressive agents or patients who are HIV positive. So see, the number of immunocompromised patients are increasing, and because of that, there is increased risk of primary CNS lymphoma. There are two kind of patients. One, immunocompetent, and second is immunocompromised. In both, what there is primary CNS lymphoma, but there is increased incidence, especially in the patients who are immunocompromised. What is the most common type of primary CNS lymphoma? Obviously, it's non-Hodgkin's lymphoma, and the most common type is what? DLBL, diffuse large B-cell lymphoma. Now, since it's a lymphoma, it's very responsive to glucocorticoids. And you must be knowing one simple logic that lymphoma anywhere in the body, biopsy is mandatory for diagnosis. So since biopsy is mandatory for diagnosis of lymphoma anywhere in the body, even for brain lymphoma, we have to go for biopsy. What kind of biopsy is done? It's the stereotactic guided biopsy. One precaution should be taken. What? That before taking biopsy, steroids should not be given. Why? Because steroids are having cytolytic effect on the lymphoma. Sometimes lymphoma disappears after giving steroids, and that's why this primary CNS lymphoma is known as ghost tumor. Why? It disappears after giving steroids. So we have to take the precaution that before giving steroid, biopsy should be taken. In these cases, we have to give chemotherapy, and in chemotherapy, one of the option is what? High dose methotrexate. So see this question. All of the following are true about primary CNS lymphoma except most common type in immunocompetent patient is DLBL. Correct? Glucocorticoids should be given before biopsy to reduce the risk of edema. This is incorrect. Why? Because it is having cytolytic effect and lymphoma disappears. So we have to withhold glucocorticoids. Stereotactic biopsy is necessary for histological diagnosis. Correct? High dose methotrexate is used in the treatment. Correct? So correct answer for this question is B.